scratch from the diagnosis of MSLD up till the available treatments and future treatments that are also potentially available. Okay. So, yeah, so just a few housekeeping rules. Some of you have joined us online and some of you are present in person. So this is the, we'll be sharing the link also. I'll share the link in the follow-up email, which you'll get. And so basically it's a technochronology integration. So if you scan this link, you will be taken to the technochronology site where you can access the link. And from this access, you will be able to get more additional material. We have a lot of extensive material, some mini applications, and the presentations and other things available on the system. So there will be more detailed analysis of what you can learn, right? So this is the thing. And if you want to follow this presentation, then this is the QR code for the same. So you'll be able to see the presentation in your mobile screens or your device, wherever you're using, so that you can access this virtually. Okay, so with this, I'll share the links again in the few minutes thing. So when you join the said link earlier, this is what it will look like. Just click on enroll for free, and you'll be able to enroll to the entire system. And again, if you're signed up to the webinar, you will, I'll share the links. You will get the link on the follow-up email also. So you can check that out as well. Okay. Right. So let's start with a case. And we'll allow you to unmute yourself and ask questions if you want. So if at this point of time you have a question, you can raise your hand. So please feel free to stop me if you feel that you have a question, and then we'll take it forward from there. So we have this Mr. Kumar, who is a 45-year-old male. He's working as a mid-level executive in an accounting firm. He's been recently transferred to Ahmedabad, and he was asked to get a health checkup as a part of the routine care for his for the employers, right? So that's what he was told. So he came for a routine health checkup. Okay. So these are the things. Again, he has no symptoms as such. He's otherwise okay. He has had previous health checkup, which was 5 years back, but doesn't remember the earlier status. And if you see his family history, is a strong family history of type 2 diabetes. His elder brother and mother both have diabetes. His father had a CV stroke at 45. His grandfather had a cirrhosis of liver, but then the cause of that was not known. And if you look at his personal history, he consumes about 20 grams of alcohol per day. So if you go to the technochronology system, there we have made a calculator also, so you can calculate. A lot of people may not know exact the amount of alcohol. Why this is important? Because now the modern classification of MSLD involves the amount of alcohol intake to say whether it is MASH or it is MET ALD. We'll come to these points in a minute. He, like most of us, lives a sedentary lifestyle, and he has a little bit of daytime somnolence and snoring. Okay, so these are his history. If you look at his clinical parameters, vitals, his blood pressure is slightly on the higher side. Again, his BMI is 28.4, which from an Indian classical category puts him into obesity range. Waist circumference is also 102 and has acanthosis nigricans on his neck. So this puts him in a typical metabolic syndrome spectrum, right? And if you see the new guidelines, so Dr. Anup Mishra's paper on obesity, it's very clear now, the new definition of obesity for Indians: anybody with a BMI more than 23 with one evidence of central adiposity, for Indians, waist circumference, Indian males more than 90 centimeters is considered central adiposity. So this guy is 102 centimeters with a BMI of 28, both of which makes him based on the current evidence as a obese category. So let's look at his labs, and his HbA1c 6.2. So he's clearly in a pre-diabetic stage. Look at his other parameters. This is a pattern. This is a real patient. We've taken his real data, and this pattern is very typical. You see in a lot of healthcare checkups, right? So these are, and especially of people of this age and even younger people, we see this type of pattern very commonly. So the SGPT, SGOT is also elevated. You can clearly see here. And look at his other reports. And on ultrasound, he has a grade 1 fatty liver, and an echo, there is a diastolic dysfunction. So again, a very typical lab checkup, routine health checkup pattern that we see. Now, one thing whenever I see a patient, and I think this is a very essential way of looking at things in a modern spectrum, is that we see for evidence of adiposity. And I always said this in a lot of my other talks as well, and I keep saying this: the actual disease is the unifying theory for most of the metabolic disease that we see is adiposity. Okay, so the disease is adiposity actually. And type 2 diabetes, MASLD, other things are basically consequence of adiposity. Okay, so adiposity is the main disease that we need to really look at. Does this patient fit the metabolic syndrome criteria? It easily fits into the metabolic syndrome criteria. So if you look at his waist circumference, look at his lipid profile, if you look at his pre-diabetes status, hypertension status, all this makes him into a very typical metabolic syndrome criteria. And if you look at his anthropometry and waist circumference, all of this fits into that. Again, all of these comes together. So if you see the biochemical markers also, the elevated triglyceride and elevated SGPT, both of it fit into this category. And further down, if you look at his other findings, he's pre-diabetic, he's hypertensive, he's having grade 1 fatty liver, and he is having probably OSA. All of this also fits into the category of someone who is in a metabolic syndrome or who has evidence of adiposity. Okay, now one useful test. Now we do this HOMA IR and all that. I don't, it's not a very useful test. A test which is actually more useful in a modern setup. So I would suggest, don't do HOMA IR. HOMA IR is a very good epidemiological test. It's not a very good, because the insulin assay is not a great assay. Insulin, as we know, will have a lot of fluctuations, and hence the HOMA IR value can also be often, falsely, unless the patient is very severe insulin resistance or very clear insulin resistance, the differentiating factor is not that great. The easier test, which is better and much more easier to interpret and easily accessible, because this is part of the routine checkup, is what is known as TYG index, that is the triglyceride glucose index. So triglyceride glucose index, so that's the test which is more robust. Pretty hypocalcemia wala hai patients. Right. So that yeah. So the TYG index is the one which is more useful. It's a simple, cost-effective biomarker, and it is used to assess insulin resistance, and it predicts the metabolic and cardiovascular risks better. Right. So I'll just tell you what the index is and how you calculate. This is again very simple to do. So you need a logarithmic scale. So you actually need a calculator, or a, these days AI can do it. So use a fasting glucose, a fasting triglyceride, and fasting glucose value. In this page, the values, the triglyceride is 279, and the glucose and the TYG index is 9.59, which is the calculated result of this. Again, what is the cutoff? So typically a 4.5, as you can see here, is the cutoff. So if a patient has value more than 4.5, he's said to have insulin resistance. So a better test than doing a HOMA IR is to do a TYG index. And there are now a lot of studies actually looking at TYG index as a good marker, predictive marker of these type of complications. Okay. Now, let's then look at the disease which we are going to discuss today, right? So let's look at the modern definitions for MASLD. And what is MASLD and how do you define it? So there are three, there's one more, which is alcoholic liver disease. There are three clinical criteria, four clinical situations which we need to look at. So first, what is MASLD per se, right? So MASLD is when you have fatty liver. उसको एक बार कैल्शियम इन्फ्यूजन देके और फिर कल ओपीडी में. So if you look at his fatty liver, it's if you look at his MASLD criteria. So for criteria, what we need is we need a fatty liver. We need at least one cardiometabolic risk factor like dyslipidemia and obesity. There should be no other evidence of steatotic liver disease. Alcohol consumption is important. We'll come to this point, right? And previously, this was known as MASLD. Another term which we now use, which is now replaced NASH, is called MASH, which is metabolic associated steatohepatitis. Now, steatohepatitis is very difficult to diagnose clinically, so it requires a biopsy. the diagnosis is by biopsy. Well, we'll come to this caveat in a few minutes in the upcoming slide. A new category which has now emerged, which is very important. I think it's a very important category because a lot of patients actually do fall into this category, and that is known as MET ALD. That is metabolic associated liver disease with alcoholic liver disease. So it's not, the patient is not purely having alcoholic liver disease, purely not having MASH, right? So this is the in between category, and this is where we define when you have an alcohol intake between 30 to 60 grams in males and 20 to 50 grams in females. So when you have this category of alcohol intake with other criteria of MASLD which is fulfilled, then this patient is said to be having MET ALD. Okay, so this is the new criteria. Now, one thing in liver, I think we need to understand is very important for liver understanding hepatology per se. In liver, you have one hit, patient can survive. When you get two hits, the patient, the cirrhosis progresses very fast. The fibrosis progresses very fast. Patient lands up with more severe disease compared to a single hit. So if the patient already has MASLD and patient then develops, has alcohol intake, you have two hits which are happening. And because of that, the patient is more likely to develop fibrosis compared to somebody who just has one of the two. So that makes it a challenging situation. Okay. So does this patient fit into MASLD? So like we saw, the patient requires some evidence of steatosis. So either in this case, we had the ultrasound, but you could have a fibroscan where we look at the CAP value. We'll discuss that as well. Or you could have maybe somebody has done a biopsy, right? Or any other event. But simplest is and most non-invasive is to do an ultrasound. What about the alcohol intake? Now, the criteria for MASLD is that less than 30 grams of alcohol in males. So he fits into that. He takes alcohol, but it's less than 30 grams. So it takes 20 grams. And there should be evidence of metabolic syndrome, right? Which this patient has plenty of evidence of metabolic syndrome. So he has hypertension, he has pre-diabetes, dyslipidemia, waist circumference, etc. Right? So this entirely fits into a category of an MASLD. Okay. Now let's look at the liver function test in this patient. Now, if you go by the recent cutoffs, so again, a lot of the times the labs also do not give the right cutoff value, right? The labs are often lagging behind in terms of the cutoff value which they give. The AASLD, that is American Association for Steatotic Liver Disease, now very clearly gives a cutoff range which is much lower than what it used to be earlier. So when you have the the SGPT value, ALT value, more than 25 in females and more than 35 in men, this is considered to be high. Okay, so a lot of our patients do fit into 33 in men. It's considered to be high. This patient is 57, right? And the male cutoff is 33, so it's clearly above the cutoff, right? So this patient really fits into, again, from a, the SGPT, SGOT criteria, he does fit into that. Now, one useful test, which has lived the test of time, actually, this has been around when I remember first year of biochemistry, we were taught this. But it still lived the test of time, right? That's something which is still there. The AST-ALT ratio, right? And as a rule of thumb, always remember that a patient who has more of the AST, he probably has more of alcohol predominance of the disease and more of ALT elevation, that is more of a routine, MASLD form, right? Like I said, it's very difficult to distinguish. Patients will have both. So MASLD patients will be consuming alcohol. Alcoholic patients will have some amount of MASLD, right? So this is there. Generally speaking, when the AST-ALT ratio is more than 2:1, you are looking more towards a MASLD type of picture. And when you have less than 1, you're looking more at the alcohol type of picture, right? So that's the important thing, right? So the ratio is important. But what you have to remember is, even patients who have probably never had alcohol in their life, if their MASLD is progressing towards more fibrosis, the SGOT starts increasing compared to SGPT, right? So that in that situation, you will have an altered ratio, and aging will also lead to altered ratio, right? So alcohol intake, aging, and fibrosis will start altering the ratio more towards the SGOT, right? More towards the AST compared to the ALT. So when you have ALT, AST of more than 2:1, you are looking at a more salvageable patient. Whereas when you are looking at the ratio skewed, then you're looking at either a patient who is strongly alcoholic or you have a patient who's progressing more faster towards cirrhosis, right? So that's something which is there. So that's something you have to look at, right? Now, how do I say that my patient is having MSLD, right? So we of course looked at the fatty liver and the alcohol intake, but it's also important that we rule out other causes, right? So again, it's always important that MSLD is a diagnosis of exclusion, and we should rule out other cases. So that's something we should look for. We should see assess for steatohepatitis, and I'll tell you this is a very important. We'll come to this point in a few slides. Why this is important is because all the modern clinical research which is now being done, earlier they were doing it in stage of fibrosis. They were looking at F2, F3 fibrosis, but now they're looking at an earlier stage. So they're seeing whether we can start intervening at the steatohepatitis stage. The problem with steatohepatitis is that it is difficult to diagnose steatohepatitis non-invasive. So it'll require biopsy. That is the challenge, right? So if I want to do a clinical trial for a new drug for MSLD, then I should ideally be targeting steatohepatitis, but for that I'll have to do biopsy. Whereas fibrosis now can be, you can make a reasonably good diagnosis, and in fact now clinical trials for patients enrolled in fibrosis can actually be done using non-invasive markers, including FibroScan, right? Including CT scans, including CT1 MRIs, right? So you can use MRI as an enrollment criteria. But if you want to enroll a patient for steatohepatitis, you'll require biopsy because that is still the gold standard and that's not been replaced, right? So that's one of the reasons. So now the new era, the future, the race is actually to find out non-invasive markers for strongly classifying steatohepatitis. So if you can diagnose steatohepatitis without a biopsy, that's the future of this situation, right? What are the things we generally rule out? Obviously, alcohol intake, which we discussed, viral hepatitis, and drug-induced liver injury. And as Nimit Bhai would know, a lot of patients, would have a recent viral infection, right? And they'll come to the hospital, right? So they come for the routine health checkup, but they recently had some sort of a viral infection. So again, it will be a good idea that you allow that stage to kind of wane through, and then you come back and check the status again. Okay. Now, what about USG? Right now, there is a lot of misunderstanding. A lot of patients come. Pehle mera grade 2 fatty liver tha, grade 1 ho gaya, right? Yeah, grade 1 tha, grade 2 ho gaya. USG is not a very great test for defining. It is good for diagnosing whether the patient has hepatitis. It is very useful if you have a situation where you want to diagnose fatty liver, but the grading is not that great, right? And the change of the grading situation is not that great. Okay, so that's something which we have to understand, right? Now, first and foremost, how do you say the liver is fatty, right? So when do you say fatty liver? So what you have to see is ecogenicity of the liver. And what you have to do is you have to compare the liver ecogenicity with the ecogenicity of the kidney, right? So renal ecogenicity, right? So if it is as bright as the kidney, it is hyperechoic, right? So that's something you have to consider. So if it's as bright as kidney, which is on the left side, you can see it is probably brighter compared to the right side, where right side you can see more of portal vein and other things also more clearly, right? So right guy is probably okay. The left guy is probably more hyperechoic and you're looking more at a thing, right? Now, there is a grading system just for our knowledge because it is a little bit outdated, but we still need to, it's been used, so we need to know. What is grade 1, grade 2, grade 3? So grade 1 is when you are able to see the portal vein. There is mainly hyperechoic, but the other structures you're able to see. Grade 2 is when the portal vein starts disappearing. So this is grade 2. So you're not able to see the portal vein. So if you're not seeing portal vein, it's grade 2 fatty liver, but you're able to see the diaphragm. So if you can see the diaphragm, but you can't see the portal vein, it is grade 2. And when you can't see the diaphragm also, it is grade 3. So this is grade 3 fatty liver, right? Now, of course, when we didn't have FibroScan and when we, did not have, the other markers, there were other markers of cirrhosis we used to look for in ultrasound. Also, that migration does happen. So if the patient loses significant amount of weight, he will go from grade 3 to grade 2. But at the same time, you have to understand that this is not the hard marker of, and it is, a lot of this is operator dependent, right? So these are not, they're very subjective, right? They're very subjective markers, right? A lot of times patients come with echo reports saying that, oh, pehla hamaru 56% ejection fraction or 55% ejection fraction. Remember, ejection fraction, if you've seen anybody do an echo, it is very roughly estimated, right? So it looks like 50%, looks like 40%. There are objective ways of doing it, but that is generally not done in a routine. So when you see a radiologist do an ultrasound for fatty liver, this is something which they quickly see a grade 2 fatty liver, grade 3 fatty liver, right? So don't depend on the grading of fatty liver to say whether your patient is improving or worsening, right? So look at other, now we have much better markers, which you should probably look at, okay? And coming to the markers. So the first question was, did the patient have MSLD? Yes, right? Second question was, does the patient have steatohepatitis? That we can't do without a biopsy so far. Third question is, does he have fibrosis? And this right now we can determine without even doing a biopsy, right? So of course, biopsy will remain gold standard, but there are now better ways of looking at these things, right? Now, so this is the algorithm which you have to follow, right? What you see on the right side. So first thing you do when you have a patient who comes with MSLD, you do the FIB-4 score. Very simple score, right? Just requires routine parameters like your age, AST, ALT, platelet count. Very simple, right? Simple to calculate, right? There is a calculation, and very simple to interpret also. Now, if your FIB-4 score is less than 1.3, the patient is not having any fibrosis. So just monitor the patient and keep the patient and your follow-up. If it is more than 2.67, right, then you have to definitely send the patient to a hepatologist because the patient is already having a little bit of advance in terms of fibrosis. But when you have the value between 1.3 to 2.67, that is where you do a fibroscan, right? So fibroscan is useful when you are having the intermediate value, and that intermediate value is where you are able to reclassify the patient, whether the patient is dealing with, where you're dealing with, whether you want to upgrade the classification or whether you have to downgrade the classification, okay? So we'll discuss the interpretation of fibroscan in the next few slides. But the point here is that the first step is to do a FIB-4 score. Easy to do, easy to calculate. There are easy online calculators available. Just put in the value. And now again, with AI, you can do this very easy. You'll just need the routine parameters, right? So, as Dr. Preeti knows, platelet count is something which is required. So when you do a CBC, sometimes, you have CBC without platelets. So we always say CBC with platelets. The problem is that automated counters are often problematic. So the problem with FIB-4 score is that you're still again dependent on platelet counts, which are not that good assay, but at the same time, that's what we have right now. Okay, so that's an important parameter. Okay, now, so these are the cutoffs we already discussed, and it's a useful test. Just caveats: it's not meant for people with extremes of ages, right? So less than 35, it has not been validated. More than 65, you require actually different cutoffs. So you can, there are papers available. So more than 65, the cutoff values we are not very sure about, what is the right cutoff. And less than 35, again, we don't have data for that. So it's an ideal test for 35 to 65, right? Beyond those ages, it's a little, you take it with a pinch of salt, okay? Probably do fibroscan because fibroscan has more validation for these extreme ages also, okay? Okay, so FIB-4 score, let's look at our patient. So our patient, Mr. Kumar, has a FIB-4 score of 1.64. Cutoff is 1.3. So again, he fits into the middle category. So basically, he is now a candidate for doing a fibroscan. Okay, so let's look at a fibroscan. Okay, so fibroscan is actually a trademark. Okay, it's a trademark of a company. So when we use the word fibroscan, it's like saying Lasix or it's like saying Lantus. You're using a trademark. Okay, the actual term is transient elastography or vibration controlled transient elastography, VCT. Right now, it's a patented system, right? So the transient elastography system, which is done by this company, is patented, right? So it's a, more or less, but there are ultrasound machines also have transient elastography as an option, which are using other protocols. So most ultrasound machines have transient elastography, but that's not same as fibroscan, okay? Because that's a different, system which they're using. These guys have a patented technology when they're saying their patent is going to be off in a few years, so you'll have more machines at a cheaper rate. But that is one of the reasons why it's very costly, okay? Because it's patented, right? So that's a problem. Now, when you do a fibroscan, you need to measure. There are two values which you'll get. One is the CAP value, and other is called the LSM value, right? So let's see a sample report. So this is a sample report of Mr. Kumar, okay? So you see the two values are shown. One is the CAP value, other is the KPA value, right? CAP value is a value for steatosis, fat content. The KPA value is the value for fibrosis, okay? So simple interpretation. Let's not make it complicated. What you see down is the, whether it's a reliable test also. So again, when you see those pictures, it's basically showing, especially obese patients, you'll require a different probe. So there are other things we have to look at. Let's not get into those details. The point here is, what you have to see is relatively look at these two values, assuming that the FibroScan has been done properly by a trained operator. These are the two values you have to look at. Okay. Now let's see the interpretation of that. Okay. So look at the CAP values. So CAP value less than 238 is considered to be S0, that is no steatosis. 238 to 260 is mild, 260 to 290 is moderate, and more than 290 is severe. Now the good part is, unlike the ultrasound, which is, more subjective, this is actually objective. You can actually follow up these patients with steatosis. So if you want to see whether patient's fat has reduced from the liver, or you want to do a clinical study where you want to look at the reduction of fat, you can actually use CAP values, right? And one great thing is actually looking at the patients, when they're losing weight, look at the CAP, look at how it's coming down, right? And it's a very good marker of seeing whether the patient is actually mobilizing the fat. Okay. Second is LSM, right? So this is the liver stiffness marker, and which is measured by the KPA value, right? Now, typically, if the value is 2.4 to 5.5, it is generally considered normal. 5.5 to 8 is F1 fibrosis, early fibrosis. 8.1 to 10.8 is F2 fibrosis. So if you do clinical trials, if you see the existing legacy clinical trials, they enroll patients with F2 and F3 fibrosis, right? So this is the values where they enroll the patient, right? They don't take advanced cirrhosis because it's not going to help that whatever drug they've come up with. And they're not going to take F1 fibrosis because again, it's very mild, right? So they're looking at F2, F3 fibrosis. Most enrollment criteria for MASLD related trials have enrolled patients in this group, right? So F2 is 8.1 to 10.8 kPa, and F3 is 10.9 to 14.2, 14.9 kPa. And when you have more than 15 kPa, it is almost patient is having cirrhosis, stiff liver, right? So they'll find other features of cirrhosis also, and there'll be portal hypertension and other things also on ultrasound. So this patients will be picked up on an ultrasound also. But looking at the other grades, these other things in the pyramid, these patients will be picked up earlier with a FibroScan and will take time before they see these features on ultrasound. Okay, so FibroScan is actually more sensitive for making a diagnosis of your patient. A lot of times what happens is, if you talk to hepatologists also, one of the major problems is that they tell us that patients come very late to us, right? Patients come when they already have advanced cirrhosis. Patient already comes, first time they are diagnosed with cirrhosis when they have first hematemesis, right? Or when they come with hepatic NCAF, or when they come with ascites, right? So already patient is having a decompensated cirrhosis, right? And that's, a stage where you can do little. So if they come and that you do a FibroScan, you pick up these patients at an early stage, you can actually intervene. And this, remember, FibroScan is not just for MASLD. It is also valid for patients with hepatitis C and hepatitis B. So other forms of liver disease also, FibroScan is a useful test, right? So again, it can be useful for early treatment. Okay. And then comes the MRI. And now MRI is now fast emerging as a very useful test for not only diagnosis, but also prognostication of these patients. In fact, to that level that now if you're doing fibrosis related thing, we actually now, the new FDA mandate says that you actually don't even require to do a biopsy if you're just doing, a trial for fibrosis. You can actually use MR elastography for as a corollary of that, right? Now, MRI, there are three sequences which are useful. One is MRI PDFF, which is the proton density fat fraction that is made for diagnosis of steatosis. So just like when you're doing FibroScan, you're looking at CAP and KPA values. Here you're doing an MRI PDFF sequence for steatosis, and then you're doing MR elastography for fibrosis, right? So specifically, if you want to look for fibrosis, look for MR elastography. And third thing, which is now fast emerging as a very useful test for steatosis, or so for steatohepatitis, is what is known as CT1 MRI. That is the iron corrected T1 mapping MRI. That's a new sequence. Remember, all these mainly it's software. So if you have a 3 Tesla MRI, you just require software, right? It'll do the interpretation. So you don't need an extra thing. This is basically software based, right? So you require that software, and that software should be there, right? And I'm sure some of these software may be patented and expensive, so maybe the test will become expensive. But at the same time, these are available to you. And in fact, MR elastography and T1 corrected mapping, they say, will fast replace biopsies in future, right? So that's now there's a lot of data now emerging with these MRI sequences, right? So these are the useful MRI sequences. There is something called a MAST score, which uses a T1 a CT1 MRI along with an AST value, and that is very now strongly correlated with steatohepatitis. So like I said, steatohepatitis as of now can only be diagnosed reliably with biopsy. Now there is emerging data that you can use T1 weighted MRI actually to do it, right? So right now, of course, still the guidelines for trials suggest that you have to use biopsy, but at the same time, in future, again, that will also change to non-invasive ways of looking at it, right? So again, still currently very expensive and still a little bit difficult to really convince your patients to do it, just for the fact that but at the same time, if you have a family member or something, want to really look at, this is the one you should be doing, right? Okay, now, so this is the diagnostic aspect. So if you look at Mr. Kumar, at this Mr. Kumar, who, if you see, let's see his report. So this was his report. So he basically came to you for a routine health checkup, and his FIB4 score was somewhere in middle. So then you went for a fibro scan, and this is where you looked at the CAP and KPA values, right? If you see the interpretation, like I said, he would fall into with a value of 280, he'll fall into moderate steatosis, and he will fall with this KPA value into F2 fibrosis, right? So he's already having F2 fibrosis. So he's already having fibrosis. This patient is somebody who needs intervention, right? So that's something which is important, right? So though at a face level, he'll see, mujhe to sab theek hai, koi problem nahi hai, theek hai? But if you see dig deeper, he's actually already having F2 fibrosis, right? And this is a patient who you can actually salvage with good treatment, right? So that's something which is useful. Okay. Now, what are the things you can consider? Of course, lifestyle measures, medications, regular follow-up, and certain patients will be candidate for bariatric surgery. So remember, bariatric surgery also, one of the things which has been found to be useful is that MSLD also reverses, right? But the catch with bariatric surgery is that if the patient is already in the cirrhosis or higher grades of fibrosis, he can actually decompensate, right? And patients with lower grade of fibrosis will not get any benefit. So it's that middle grade, right, who are actually good candidates from this perspective, right? So, well, either they go for transplant or they go for bariatric, right? So that's something, you have to keep it, right? And in fact, nowadays, a lot of patients amongst the transplant patients who are eligible, a lot of these patients have cryptogenic cirrhosis. They actually have MASH related cirrhosis, right? So that's something which is now fast becoming the number one reason for transplants worldwide. Okay, now let's look at the management aspects. So you can do lifestyle measures, you can do pharmacotherapy and bariatric surgery. So these are the options. Let's look at lifestyle measures. So how much weight loss is good weight loss? So when you have a patient with steatosis alone, the target is 7 to 10% weight loss, right? And now numerous studies have shown that this amount of weight loss reverses steatosis. You can actually map this patient and start following their fibroscans and show that he is progressing, right? So that's something which is useful. Physical activity, of course, dietary changes, right? But alcohol consumption, what amount of alcohol is good? No amount of alcohol is good for this patient who is already having MSD, right? So even that 20 grams of alcohol he's taking, that should be stopped, ideally, right? Ideally. So there is right now no value which is considered safe in a patient who is already established with MSD. So that's something which your patients need to understand. Now let's look at the pharmacological aspects, right? So right now, this space is an emerging space. In fact, if you see, if you're somebody who follows, money in terms of how these pharma companies are actually looking at, there are two areas which are now currently the hottest areas for investments by pharma companies. Type 2 diabetes is gone, right? That era is gone. Nobody is now investing in type 2 diabetes. Obesity is one, MSLD is two. Right, so these are two areas, at least in the US space, where they're looking at cardiovascular disease are also over, right? Now, very slow emergence of treatment there. These two spaces are now fast becoming the new hottest area in terms of rat race for emerging treatments. Now, what are the things you can do right now? Okay, so right now we have certain type 2 diabetes medications which are repurposed for MSLD. There are certain specific drugs for MSLD which are there. Thirdly, and which is very important, and this is something which is important for all of us to understand, that patients with MSLD will are more likely to die of cardiovascular disease before they die of cirrhosis of liver. So they'll actually be lucky if they reach cryptogenic cirrhosis stage, because if they don't intervene, there are patients, some of them will actually die of cardiovascular disease. Okay. So this is a, I don't know if I remember when we used to give entrance exams for postgraduate, they used to say that what is the most common cause of patient death in patients with CKD? It is not CKD, it is heart disease. So CKD patients die of heart disease, type 2 diabetes patients die of heart disease, and MSLD patients die of heart disease before they die of the disease which we are talking about, right? So statins are as important for these patients as any of the other drugs, right? Aspirin also, there are now studies which have shown that the platelet changes which happen because of aspirin, that can actually help for cirrhosis also. So aspirin and statin ideally can be prescribed to these patients because they will not only help the cardiovascular aspect, but there is some evidence to show that they actually help the liver disease aspect also, right? So that's something which is important. And vitamin E is one drug. So we give all kinds of vitamins and all kinds of UDCAs and all that. None of them have evidence. The strongest evidence actually, unfortunately, comes from vitamin E. Right? There's one trial called PIVENS trial, which has shown benefit in non-diabetics, and interestingly, did not show benefit in diabetics. So when you have non-diabetics with MSLD, like this guy, vitamin E is a proven therapy, right? With a clinical trial. We'll come to all these drugs. Now, let's look at any drug, right? When you are potentially considering prescribing to your MSLD patient, what are the things you should look at? One is it approved for MSLD? Or is it approved for something else and you are repurposing it for MSLD? Secondly, does it have any benefit beyond weight loss? So now we have all these new drugs which are emerging for weight loss. Most of these drugs will claim benefit for MSLD. But is that benefit because of weight loss, or is that benefit because of the drug itself? That's a question we need to ask. I mean, doesn't matter to the patient. Patient will be happy to lose weight and also have the benefit. But from a clinical perspective and from a clinical trial perspective, you should look at that whether there's benefit beyond weight loss. What is the safety profile? That's important, of course. Does it have any anti-inflammatory effect? So does it work in the steatohepatitis stage? That's important. What is the impact on fibrosis? So when you look at clinical trials for these are the two questions you should ask. Does it help in steatohepatitis stage? Does it help in fibrosis stage? Right? And even if the patient has already, so fibrosis and steatohepatitis is fine. Steatohepatitis can be reversed, that is now well known. Fibrosis can be prevented from progressing, that is well known. But the important question, and this is a very important question because US FDA recently talked about this in their approval status. Does it reverse fibrosis? So if I already have fibrosis, if I already have F3 stage, can I go to F2 stage? That's an important question, right? So again, newer class of drugs, this is a question which they have to answer, right? That whether a lot of drugs will claim that we prevent fibrosis. Great. Do you reverse fibrosis? That's an important question, right? And not many drugs have actually stood the test of time with this. So that's a very important area, which now US FDA wants that, this is something they should be looking at, right? Okay. How much weight loss helps for what stage? So 5% weight loss can cause regression of steatosis. 7% causes resolution of MASH. So if the already has steatohepatitis, that will help. 10%, there will be some amount of fibrosis regression. So even weight loss will lead to fibrosis regression. And if your patient is diabetic, 15% weight loss will actually lead to diabetes remission also, right? So this is the spectrum you should look at. So how much weight loss you should target? Look at the patient's clinical situation, and that is what you should be kind of boldly suggesting in terms of target. Okay. Now, further along, let's look at the medications. Okay. So let's look at the currently approved medications which are there. There is only one drug each. Only one drug currently, which is US FDA approved for MSLD, and only one drug approved in India for MSLD, right? So this is very clear right now. Only drug approved in the US is resmetirom. A lot of drugs will come and make claims. None of them may be approved, right? Some of them are not even asked for approval. The second drug which is now coming close to approval is semaglutide, because they just recently had a new data which they are now submitted to the US FDA for approval. Tirzepatide actually has data, but they have not asked for approval, right? Which is a very interesting strategy, right? So they're not asked for approval. Maybe, probably they're looking at, they have another drug in pipeline, which may be even more powerful. Probably that is the reason why they're not putting for tirzepatide for approval. Only one drug approved in India is saroglitazar, right? So interestingly, the only drug approved in India for MSLD is saroglitazar. So your UDCAs, obeticholic acid, none of them are approved for MSLD. None of them, right? In fact, probably they should not be used also because the evidence is very sketchy for these drugs. But the drug which is approved is saroglitazar, right? Which is important. Now, let's look at resmetirom. Why should we look at resmetirom? Because it is the only US FDA approved drug. There are reasons why. There's a reason why this is the only drug which is approved. One is that, and again, why it's important for us, because apparently resmetirom is going to come to India, apparently sooner than we thought, because it is losing its patent this year. So this has been around for a long time. The trial came actually much late, right? Compared to the patent, and this drug is actually going to lose its patent and going to come to India as a generic drug, which is great, right? Great for our patients, right? Why this is very important? Because this is the only drug in their clinical trial which has actually shown good amount of fibrosis regression. And now they are doing trials for advanced cirrhosis also. And they are confident that it will improve the status in advanced cirrhosis. So think of this. You have these patients with cirrhosis, right, who have no other treatment, right, available to them except transplant, right? I always remember all hepatologists, when you have this patient with advanced cirrhosis, they'll go and say, we are just, giving you some treatment and we are correcting all the problem. The only treatment for you is transplant. Looking at a space where probably resmetirom may be a drug which can be offered to these patients, right? At least with compensated cirrhosis, that is what they're doing in terms of clinical trial. Decompensated cirrhosis, again, transplant is the only option, right? But you're looking at this space in between. Also, this drug is actually may have use in for lipid lowering also. Now, why all this is again very useful and very important from an endocrinologist perspective? This is an endocrine molecule. So resmetirom is actually an analog of T3, right? It's a selective T3 analog, which only acts on TR beta, right? Now, you have, thyroid receptor alpha and thyroid receptor beta. The alpha receptor is in the heart, the beta receptor is in the liver. Why this is important? Because if I give T3 to my patients, which is available in India, I am impacting the heart and I'm impacting the liver, right? Now, we don't have the safety of T3 for patients with high cardiovascular risk. So if I give T3 to my patient who is having MSLD, am I doing benefit or harm? I don't know. Potentially you can offer, but we don't know whether you're doing benefit or harm. So that's a key challenge, right? So that's why they made this selective agonist, which only works on beta, doesn't work on alpha. So it doesn't work on the heart, but works on the liver. Now, the question is, if it works on the liver, why does it work on the liver in a patient who is otherwise euthyroid? The reason is, now they found that, remember, there is T4 to T3 conversion, right? Now, the T4 to T3 conversion, which occurs with deiodinase, right? There is one way which is forming T3, but then there is one way which is forming reverse T3, right? What happens in a patient with already established liver dysfunction is that they produce more reverse T3 than they produce T3 in the liver. So this patient will be euthyroid, right? Because in the pituitary, where the TSH is being acted upon, there is no problem, right? But in the liver, where, it's an organ specific issue, in the liver, the thyroid hormone is not acting on the liver. So they develop what is known as intrahepatic hypothyroidism. And what they found is that this intrahepatic hypothyroidism actually creates a vicious cycle that leads to progression of the liver fibrosis. So what you are doing here is that you are selectively targeting, right, this, and you're directly acting on the TR beta, reducing the intrahepatic hypothyroidism, reducing the further fat deposition and fibrosis in the liver, and hence a very selective action. What is interesting is that these guys have not done the trials for initially the idea was is to actually originated as a drug as a cardiovascular drug, right? What they're looking at, does it reduce the LDL level without causing cardiac harm. They never did that trial, and it was never done. So probably in future, because it's going off patent, we don't know. But in this class of drug, you might actually find this drug actually beneficial for cardiovascular disease also. We don't know that data, but maybe. So that's the idea, right? What about the Indian hero, saroglitazar? Okay. Now, like I said, this is the only mechanism drugs which is available in India, which is approved by the Indian regulator for this, right? What is saroglitazar? So saroglitazar is a dual alpha and gamma agonist. So it has an action like pioglitazone and action like fenofibrate. So it's a combination of fenofibrate and pioglitazone in a sense. It reduces fatty acid oxidation as anti-fibrotic action also. But we have a small number of data, but actually have biopsy proven data where they have shown fibrosis regression. Also has anti-inflammatory action. So it also acts on the NASH, on the MASH stage also. So there is now data available for this. This is how it acts. The data actually comes from these trials, which are called as evidences series of trials. Evidences 2, 3, 4, 5. Right? So these are all studies. Evidences 4 was a phase 2 trial. They actually looked at the liver fat with MRI. And Evidences 2 is the phase 3 trial where they looked at the the biomarkers. Now there is one more trial which has recently been published, which has looked at the biopsy also. Right? So now there is biopsy proven. The only thing is that all of these trials have small numbers. Right? That is the only challenge with saroglitazar. Right? The only challenge with saroglitazar getting international recognition is the fact that there are clinical trials, but they are in small numbers. Right? And currently saroglitazar is undergoing a clinical trial in the US, where they're looking at larger numbers and probably might, if it works out, might get an approval. The only Indian drug getting access to a US market in a big way, which is great, right? So I think that's something which is important. Okay. So there is now evidence from biopsies also. The only problem is small numbers. That is the only thing. But as a proof of concept, this is a drug which works. And this was actually enough for the DCGI to give an orphan drug approval status in a sense for this drug for MSLD, because there's no other drug for MSLD. Okay. So that's the benefit. What about the other benefits you get from saroglitazar? So this patient, if you remember, had high triglycerides, so reduces triglyceride, reduces HbA1c to a level which is similar to what you expect from a DPP4 inhibitor, 0.5%. Little bit of LDL reduction, 21%, and non-HDL-C reduction is quite good, right? So apart from the liver benefits, you get the other benefits also with saroglitazar. Okay. And then if you look at the regulatory status, like I said, it was approved in 2020 by the DCGI. Recommended dose is 4 milligram. Recommended duration of therapy is 24 to 52 weeks. That is what the clinical trials have done. And currently we are looking at indications of non-cirrhotic NASH and diabetic dyslipidemia. These are two approved indications for saroglitazar. Okay. So this is what you are looking at. Okay. Overall safety profile is pretty good. Most of the time, we have a lot of patients on saroglitazar right now, and none of them have any major side effect to talk about. Okay, and so these are the two drugs which are available, which are approved. One of them is available in India. The other one will be available in India in a few years, maybe in a year. But let's look at the other drugs which are being repurposed for MSLD, which are mainly anti-diabetic drugs, which are repurposed for this. These are the drugs which fall into that category. So your SGLT2 inhibitors, your GLP-1RA, and pioglitazone, right? Now, obviously, pioglitazone you will only be using in a diabetic patient. So if you have a diabetic patient with MSLD, pioglitazone is a great drug. SGLT2, again, you will probably have to look indication. Just MSLD right now you can't give. GLP-1RA maybe. This is an area which probably you could use, right? Because you have trials with semaglutide and tirzepatide. Both of them have shown good benefit, right? So you can use based on clinical trial, but none of them are approved for this purpose, right? So these are the challenges. Let's look at these drugs in a little bit more detail. Now, SGLT2 inhibitor, the trial which actually showed benefit is again an Indian trial, right? Yeah. So the trial which was, it was done from Medanta, right? Where they looked at empagliflozin in patients with MSLD. Challenge with the trial is that they only looked at MRI sequences and they did not look at the biopsy. So that time, even though this was a good trial, right? It is called the ELIFT trial. It's a great trial. But at that point of time, did not get much weightage because it was not done with biopsy. The challenge now is, the good part now is that now their US FDA is actually allowing MR elastography as a surrogate for biopsies. So if they had done this trial in 2024 or 25, that would have got more recognition, because now other people are doing similar trials with these drugs without doing biopsies, right? Especially GLP-1 group, right? They already started doing trials without biopsies. So they did an ELIF trial. They actually found benefit. They did only in diabetic patients, the MSLD, and they found benefit in terms of the reduction in the steatosis as well as some improvement in the elastography parameters also, right? So SGLT2, because of the very nature that it reverses fat, has some evidence to show that it has benefit in your MSLD. So if you have a patient with, right now what we know is, if you have a diabetic patient with MSLD, empagliflozin may be a good drug. We have a similar study from dapagliflozin also published a few years after that, and you had a study with canagliflozin also. So it's again not a drug specific action, it's a class specific action, right? So that's important. GLP-1RA is the best bet currently available to us for your patient. I'll tell you why. This is the Mastro NASH trial, right? Where they actually found 59% as MASH resolution. That was called NASH that time, NASH resolution, with the lowest dose of semaglutide, which is the Ozempic dose, 0.4 milligram. Not lowest, actually, second lowest, second highest dose, right? 0.24 is the starting dose they'll come with. And then 0.4 is the upgraded dose. Yet they did not ask for FDA approval, nor did they get it. But now they have a recent trial, which they are actually going to use for FDA approval, which is not yet published, but it's there. Looking at tirzepatide has a clinical trial. But what is very interesting is, look at this MRI. This is from Surpass 3 trial. Right. On the left, what you see is the liver fatty score, which is 27.3, 52 weeks of drug, and you can see it becomes blue completely. So the fat is completely gone from the liver, which is amazing, right? So this is one, it's so fascinating to see. But this is actually, the Surpass 3 trial was not a trial done for MSLD, but they actually had some of this data and they published it independently in some of the other papers, right? But this picture is quite telling, right? So it's quite interesting to see that. Look at the fat which is being reversed, right? Which is, I think, amazing. So it has role. Pioglitazone is probably the only drug which has stood test of time. It has shown everything. It has shown fat redistribution, reduction of insulin resistance, anti-fibrotic effect also in biopsy proven studies, and anti-inflammatory. But pioglitazone is nobody's favorite. It cannot be used in non-diabetic patient. So the best bet then is saroglitazar, which is acting on the same pathway, but is approved for non-diabetic patients. So that's what makes it very interesting, right? It has shown across categories of pathology that has shown benefit, and I'm actually surprised that no pharma company, probably it will happen now, no pharma company has actually looking at analogs of pioglitazone, which are safer for your lobeglitazone, which is there, but not much, right? But this is one, I think the entire group of drug probably on the wrong path and never got the due attention which it should. All of them actually had to face, from proglitazone to rosiglitazone to pioglitazone, all were hampered by some data or the other. It is nobody's favorite, drug ever, right? So unfortunately, but it's the drug which has actually shown great benefit in liver, especially diabetic patients. Okay, vitamin E is very curious, right? Drug. It was actually a landmark study which was published in 2010 in NEJM, where they looked at vitamin E, and they took it in diabetic and non-diabetic patients. It did not benefit non-diabetic patients, but benefit. This is the trial, right? So this is the again, they're not great numbers, about 250 patients. But vitamin E, so it was a vitamin E pioglitazone kind of thing. They use vitamin E for diabetic and non-diabetic. The pioglitazone they used only diabetic patients. So this was the PVENS trial. A 96-week follow-up of the patient. And interestingly, vitamin E of 800 international units a day showed benefit in non-diabetic patients in terms of the MASH. It was a biopsy-proven study. There was fibrosis improvement with vitamin E. So again, in a sense, it is, this is the data, right? So NASH improvement, ALT reduction, steatosis reduction, inflammation reduction, fibrosis improvement. All of them actually have statistical significance in terms of benefit, right? Now, we don't know how it works. Mainly, it's probably antioxidant nature, why it works. Probably anti-inflammatory action, but it's very curious and interesting. And in fact, this is an old trial, so a 15-year-old trial. Unfortunately, vitamin E never took off in terms of the use, but this is in fact, you are doing better if you're giving vitamin E rather than UDCA, because vitamin E has benefit in non-diabetic patient. UDCA, there is sketchy data, right? So let's look at Mr. Kumar. So what would you give to this patient, right? We'll give evidence-based therapy. So there are only 3 drugs which have evidence, right? 3 things which have evidence in this patient. Remember, Mr. Kumar is non-diabetic. Mr. Kumar already has fibrosis. So weight loss, 7 to 10%, vitamin E, right? 800 international units a day, and saroglitazar. These are only 3 drugs which you can actually prescribe from evidence perspective, right? Now, what probably you could always argue is that we can give him tirzepatide, maybe, right? It's now available in India, but you will have to give it for obesity. He is obese, but you will not give it for MSLE, right? And then you will argue that he will lose 10% weight, which is great, which is argument perspective, it is fine, right? So he is a candidate for tirzepatide, indirect evidence in terms of benefit, but in terms of pure approved drugs or evidence-based recommendations, these are the 3 drugs. Apart from statins and aspirin, plus minus, again, primary prevention aspirin, we don't know, but like I said, aspirin has benefit as far as liver perspective is concerned, but no strong data to support it, right? It's just mechanical, theoretical perspective. Are you doing harm by giving aspirin? Maybe not. He's just 45, but it's a questionable thing. He's probably a candidate for statin anyway, so you should give him statin. Right. So this is what it is. Now, if you want a certificate, go to technological.com. I'll share the link. I'll just share the link again. So when you go, what you'll have to do is you'll have to go through the entire all the material which we have put in, and just keep going to completion, right? You'll have to complete all of that. And when you complete everything in the end, it will get something like this, that you have, congratulations, you have completed this, and you get a certificate. You will be, able to get a certificate. It's actually coded certificate. So there's every certificate will have individual code, right? So you can, so it's a